All right, welcome. Thank you everyone for coming today. I'm going to be presenting on GI emergencies, and congrats and good luck to all the residents who submitted their fellowship applications today. So this lecture was actually given by Dr. Jasleen Singh, who was a GI fellow that graduated last year. She was a IM resident here as well. So I took a lot of her content and adapted it for this lecture today. So I just want to make sure I give her credit. And feel free to stop me throughout the presentation if questions come up. Yeah. Should I just click through or? Okay. Yes. Yes. Okay, so we have some objectives for the hour today. I want you guys to be able to recognize common GI emergencies, be able to triage them, recognize when to call GI, how to communicate with them effectively, and know the first steps to treating GI emergencies. So this is just a general outline of some of the things we're going to cover today, like acute GI bleed, sigmoid volvulus, food impaction. We'll talk about acute pancreatitis. That's not technically an emergency, but it's something we commonly see. So these will be the topics. So I think probably the first thing everybody thinks of when they hear GI emergency is acute GI bleed. So we'll start with that and spend a decent amount of time on it. So this is defined as occurring for less than 3 days in duration. And we locate it based on the ligament of Treitz. So that ligament connects basically where the duodenum and the jejunum, duodenum transitions into the jejunum. So anything proximal to that is an upper GI bleed. Anything distal is a lower GI bleed. Upper GI bleeds present with hematemesis or melena, sometimes hematochezia if it's a brisk upper GI bleed. And then lower GI bleeds typically are going to present with hematochezia or melena if it's from like the right side of the colon. These are usually more hemodynamically stable and lower mortality than an upper GI bleed. So you can use this location to help you build your differential diagnosis. For upper GI bleed, you want to make sure you're thinking about esophageal varices, peptic ulcers, esophagitis, Mallory-Weiss. You have to think about AVMs, de la Foy, and malignancy. Those you can both see also on a lower GI bleed. And lower GI bleed, you have to keep diverticulosis, inflammatory bowel disease, rectal varices, hemorrhoids. Those should all be in the back of your mind. So I don't know if you guys know Dr. Ben Schmidt. He's the guy in the center here. He does like funny medical videos on Instagram and TikTok. He was actually a resident here 2 years ago, and he's a GI fellow now at St. Louis. So I thought I would just play this video for you guys. Hopefully it works. Click it. Sorry.
No, you're fine. It's not the most intuitive.
Hi, this is GI.
Hey, I'm one of the medicine interns. I've got a patient who just had a bloody bowel movement.
Can you describe it?
The bowel movement?
Its color, its texture.
It's like dark red, kind of liquidy. Do you want to come look at it?
Burgundy or maroon?
Are those different?
Or like a burnt sienna?
What?
Was it entirely bloody or is it like normal stool with blood in it?
Maybe I should just send you a picture.
Was it uniform consistency or like a chaotic amalgam of feces?
What's amalgam?
How does it make you feel?
I didn't touch it, but that's what it means. Was I supposed to touch it?
And the smell?
It smelled like poop, honestly.
Is it harsh or melodic?
The bowel movement?
Look into your soul and reflect on how the bowel movement makes you feel, like as it sits there before you.
I'm not in front of it anymore.
What emotion does it trigger in you?
I'm back in the workroom.
Is it bloody? Or perhaps are you the one who's bloody?
I'm sorry, what?
The one out here by the hospital.
He's going into shock, I think.
Oh, okay. Sorry, I'll be right there.
So I'm pretty sure I've had that conversation with GI, but no, they will ask a lot of details about poop. So it's a good thing to know how to describe that to them, which I'll go through. So you guys probably all know these things, but just a good reminder, hematemesis, that's bright red, vomiting up of bright red blood, or coffee ground emesis. That's going to be an upper GI bleed. Melena, that's black tarry stools, typically also an upper GI bleed 90% of the time. But if you can't find it coming from an upper source, you should also think about the small bowel or the right side of the colon or the oropharynx or the nasopharynx. And then there's hematochezia, bright red blood, or sometimes maroon stool. And that's typically a lower GI bleed, but can happen if there's a massive upper GI bleed. And those patients would typically be hypotensive or in shock. So you're working on nights, you're diligently reviewing and renewing restraint orders, and the nurse calls you and says, Mr. Jones on the 3rd floor just had a bloody bowel movement. So what's the first thing you should do? It may seem obvious, but you should go evaluate the patient. And then really, what's your first impression? Is this patient awake? Are they talking to you? Are they confused? Those are all important clues. And then you should be thinking about the history. Important elements would be how old the patient is, when the bleeding started, how much bleeding there's been, do they have a history of cirrhosis, do they drink alcohol, have they had prior GI bleeds, and scopes or endoscopy reports you can look at, any heart conditions or associated symptoms. Medications are also important. Are they on any anticoagulation, antiplatelets, NSAIDs, and then knowing the indication or why they're taking those medications. So while you're doing all this, you should also be checking the vitals. If they're hypotensive, give them volume. If they're tachycardic, they need more volume. And then your physical exam, you definitely want to do a DRE on this patient. NG lavage has kind of fallen out of favor. It does help to clear blood to help when they visualize on the endoscopy, but doesn't really change management, so we don't routinely recommend that anymore. You should be looking for signs of chronic liver disease like pulmonary erythema or ascites, and then examine their heart and lungs. Is there anything that's going to compromise having a safe procedure? You should be checking labs on these patients. You should know the hemoglobin. What's the most recent hemoglobin? Is it trending down? Is this a stable baseline for them? Platelets and INR are important. BUN and creatinine ratio is also important. So it's actually 90% sensitive for an upper GI bleed if it's greater than 30-1. And that's because as blood is passing through the small bowel, it's being absorbed and digested. So that increases or raises your urea. You're looking for signs of cirrhosis on their LFTs. What do you guys think? Should you do an FOBT on this patient? No. Yeah, I'm seeing a lot of no. So it's tempting because you want to confirm that they are bleeding and you want to prove it, but you should really just go based off your history and physical. The FOBT is a screening tool for colorectal cancer, so avoid that temptation. So there's a couple of scoring tools that we use. There's the Glasgow Blatchford score. So this is useful when you're in clinic or when you're in the ER and you're trying to decide a patient who comes in with an upper GI bleed, do they need to be admitted to the hospital, or can I manage this patient as an outpatient? So it takes into account the BUN, hemoglobin, systolic blood pressure, and the heart rate. So if they're scoring 1 or less, they have a very low risk for bleeding or mortality, so you can actually manage them as an outpatient. Anyone 2 or above should be admitted at least for monitoring and possible intervention. There's also the Rockall score. So this is useful after you've already done an upper endoscopy. So it takes into account what those findings are, like whether they had a Mallory-Weiss tear or an ulcer or malignancy. And so you really need the endoscopy done before you can calculate that, but it helps determine mortality. And anyone with a score of 2 or less is very low risk for rebleeding, about 5%, or death, about 1%. So as you're evaluating the patient who has an acute GI bleed, the nurse says to you, how should we take care of this patient? What should we do next? And first thing you want to do is get IV access. So you want 2 large bore IVs. And And we know from physics that flow is directly proportional to the fourth power of the radius and inversely proportional to the length. So you want a catheter that's short and thick. So you can see from this diagram here, this is time in minutes to infuse a liter of fluid. So you might think like, oh, a central line is great. Like we can infuse a lot of fluid in this for this patient in the ICU, but really a triple lumen is one of the slower ones. So you would want to go for like a rapid infusing catheter or cordis, or this is a 14 gauge. So you really just want something short and thick. You want to resuscitate them with IV fluids or blood products. These are going to be your goals in a patient that's bleeding. Platelets above 50, goal INR would be less than 2 in a non-cirrhotic patient, and then fibrinogen above 100 in cirrhosis. These patients should be NPO. You never know if they're going to get a scope or not. And then start them on an IV PPI BID if you have any concern for an upper GI bleed. Trend the hemoglobin anywhere from Q4 to Q12 hours, depending on how sick the patient is. And then you can give them a prokinetic like Reglan or erythromycin. This moves things along, so it helps clear out the blood or food to help visualize things on endoscopy. But you have to be careful giving that because it is like a QT prolonging medication. There's drug interactions, so just be thoughtful before you do that. Just a brief word on IV PPIs. So how they work, they increase the gastric pH and they promote platelet aggregation. So we know that they reduce rates of rebleeding in patients with ulcers post endoscopy. And they also we think they promote hemostasis in patients with lesions other than ulcers. And then what's best, intermittent versus continuous? It's not really clear. At Loyola, we do intermittent, but at the VA, we do continuous. So either way is fine. So your patient is bleeding and you find out this patient has cirrhosis. You're going to take the same initial steps of resuscitating them, getting IV fluids and PO, but you have to keep in a special consideration for variceal hemorrhage. And so these patients have a different type of management. So you'll do, again, an IV PPI BID, and then you should start them on octreotide, which is a somatostatin analog, decreases portal pressures and reduces rebleeding. And then you can give them a 50 microgram bolus and follow that by a continuous infusion of 50 micrograms an hour for 3 days. All these patients should be on antibiotic prophylaxis. We know that it reduces mortality, bacterial infections, and rebleeding. They're at much higher risk for infection than a normal patient. So you should choose something broad spectrum with good gram-negative coverage. Our choice here at Loyola is ceftriaxone, and you should do that for at least 5 days. And anyone with a variceal hemorrhage should get an endoscopy within 12 hours. Okay, so you've evaluated the patient, you've done the initial workup and management, so now you call GI. What are the things you want to tell them? Explain the history. So make sure you tell them like this patient has cirrhosis or they're on warfarin. Describe your exam. You definitely want to emphasize like vital signs and they're going to ask you about a DRE, so make sure you've done one and tell them what you've already done for the patient, which we already talked about, IV access, all those things. It's going to be helpful to make that an effective phone call. All right, so that was all about acute GI bleed. We're going to move on to a few other GI emergencies. So this one you'll probably see less commonly, but is still an emergency that needs to be dealt with quickly. So you can see here, this is like the classic coffee bean sign that you'll see on an X-ray. And so what is it? It's when the sigmoid colon wraps around itself and twists around the mesentery. That causes intestinal obstruction and decreased vascular perfusion to the colon. The patient will present with sudden onset severe abdominal pain, distension, obstipation, vomiting, and you can usually diagnose it off an X-ray. You can do a CT as well. And why is this an emergency? We're concerned about bowel ischemia, necrosis, and abdominal compartment syndrome. So how should you manage sigmoid volvulus? Definitely make sure they're NPO. Check their electrolytes, INR, platelets. First line is going to be GI, so they can do a flexible flex sig detorsion. So basically, just with gentle pressure from the scope, they can untwist the sigmoid colon. Sometimes they leave in a decompression tube to make sure it doesn't twist right back on itself. If that doesn't work, or if there's alarm symptoms, which would be like peritonitis on your abdominal exam or signs of perforation on imaging, then it's a surgical emergency. So they may need a surgical resection. All right, next topic is food impaction or ingestion of a foreign body. So these you'll probably see more likely in the ER. That's where I saw some of these, but can happen while admitted. So also good to know for that in that respect. The things you want to ask here are, when did the event occur? What did they swallow? And are they tolerating their secretions? This is an emergency, call GI immediately. The only caveat to that would be if it's above the cricopharyngeus, then that would be more ENT's territory. This is not necessarily something you all need to know, but just interesting to know like how emergent the endoscopy is for GI. So emergent cases would be patients who have obstruction of their esophagus. So they're not able to swallow their secretions, or they can't sip thin liquids. Other things would be disc batteries that are in the esophagus, or sharp pointed objects in the esophagus. Things that are less urgent would be coins in the esophagus. You can wait and monitor that. Disc batteries or cylindrical batteries that are in the stomach and don't have any signs of injury, those you can monitor for 48 hours, but after that, they should be removed. If it's a food impaction, you can try glucagon 1 milligram IV to attempt to relax the esophagus and promote passage of the food bolus. Could be urgent or emergent, again, based on the alarm symptoms. So tolerating liquids, drooling. Moving on to acute cholangitis. So this occurs when biliary cholestasis and infection results in a systemic inflammatory response. So you have to have that inflammatory response to differentiate it from something like choledocholithiasis. How do we diagnose acute cholangitis? So we have the Tokyo guidelines here. To make a definite diagnosis, you should have one from A, B, and C. So that would be systemic inflammation like fever, white count, elevated CRP, jaundice, elevated T-bili, and then evidence on the imaging like biliary dilatation, or stricture, or stone. And then ERCP is the gold standard for diagnosis. Management starts with stabilizing the patient, IV fluids and antibiotics. And then you can consult GI therapeutics for biliary drainage. They can do like a sphincterotomy, stone removal, stent placement. If they have like strange anatomy like Roux and Y, you can do like EUS guided drainage, or perc chole, or surgical drainage. All right, so acute liver failure. This is a rapid deterioration of liver function due to an acute insult. So by definition, these patients will have hepatic encephalopathy, and they will also have a prolonged prothrombin time. So their INR has to be greater or equal to 1.5. And they can have elevated aminotransferases. Duration would be less than 26 weeks. And then there should be no pre-existing liver disease. So you won't see a cirrhotic with acute liver failure. Lots of different causes for acute liver failure. Drug-induced is a big one. Tylenol can happen even non-intentionally. Just over 4 grams of Tylenol can push you over the edge. Viral hepatitis like Hep B, Wilson disease, autoimmune liver disease, acute fatty liver of pregnancy, ischemia malignancy, and Budd-Chiari. There's a really big workup you can do, not something you need to memorize. These patients, you can consult hepatology and they'll help you determine like what kind of workup needs to be done. But you could start with like an acetaminophen level viral serologies. This is just a table of all the, it's kind of blurry, but all the drugs that can have been indicated as causes of acute liver failure. So lots of things can do it, and like herbal supplements as well. So you really got to be careful with the liver. So lots of complications can come from acute liver failure. This is really more like ICU level management of cerebral edema or intracranial hypertension. And you base that off of the grade of their encephalopathy. So someone with a low level of encephalopathy, you can do like a brain CT to rule out other causes. You can treat them with lactulose. Anyone who's like grade 3 or 4, this is when they're starting to like get into a coma. Or like unarousable, you should intubate them. You should consider like neurosurgery consult to place an intracranial pressure monitoring device. They may have seizures, all these things to kind of minimize herniation or edema. They can have all these other complications as well. You got to be really careful about infection. You should do a broad infectious workup, start antibiotics early if you're concerned. Coagulopathy, you can give them vitamin K. If they're having any kind of invasive procedure, active bleeding, you can use FFP. And then they should have like some kind of nutrition, vasopressors as needed. So in patients who are not responding, they're not spontaneously recovering, or they're not responding to whatever treatment you're giving them, liver transplant is an option. It's really beneficial to people with a poor prognosis. So that again is based on their grade of encephalopathy. So spontaneous recovery is less than 20% in patients with a grade 4 hepatic encephalopathy. And then King's College criteria was developed for liver transplant in acetaminophen-induced liver failure. So if they're getting acidotic, or again, their encephalopathy is bad, those would be indications for transplant. And then they extrapolated that out to other causes of acute liver failure. All right, colonic pseudoobstruction. You guys probably know this as Ogilvy's syndrome. So it's an acute dilatation of the colon in the absence of an anatomic obstruction. This patient will present with abdominal distension and pain, nausea, vomiting, constipation. Their abdomen might be tympanitic to percussion, fever, peritoneal signs. So the increasing diameter of the colon puts tension on the thin colon wall, and that causes ischemia and perforation. A lot of different causes for this. Big one is medication, trauma, surgery, and it goes on and on. The number you want to remember is 12 centimeters. So if the cecal diameter goes above 12, that's an emergency. And your management is going to be based off that. So if they're less than 12, you can do more conservative management. So treat the underlying disease, stop anti-motility agents like opiates and calcium channel blockers are big ones. Make them NPO, IV fluids, replete electrolytes. You can place an NG tube to suction. Make sure these patients are getting up out of bed, walking around, turning in bed. And then once you cross 12, you can consider using neostigmine. You should be in a telemetry unit to give that because it can cause bradycardia. If that doesn't work, you can do colonoscopic decompression, or surgery. You can place a cecostomy tube or do a subtotal resection. Okay, acute pancreatitis, like we said, this is not a real emergency, but it's something you'll come across a lot. So to make the diagnosis of acute pancreatitis, you have to have 2 out of the 3 of the following. Characteristic abdominal pain, so that would be like epigastric pain that radiates to the back. Amylase or lipase greater than 3 times the upper limit of normal. That's based on whatever your hospital system uses as the upper limit of normal. And then radiographic evidence of pancreatitis on cross-sectional imaging. So you don't technically need imaging to diagnose pancreatitis. Can cause a lot of complications like fluid collection, necrotic collection, respiratory failure, shock, renal failure. There's a few different severity tools we can use. one of the older ones is the Ranson's criteria and the Apache 2 score. And then more recently, there's the BISAP score. So that's the bedside index of severity in acute pancreatitis. It was developed hopefully to make calculating this a little easier because these ones have like 9 or like 11 elements to them. So it predicts the risk of mortality in acute pancreatitis. And these are the different elements. So BUN greater than 25, impaired mental status. They should have 2 or more of SIRS criteria, age greater than 60, or a pleural effusion. And if you're scoring 0 to 2, your mortality is pretty low, but once you hit 3 and up to 5, it increases up to 22% mortality. So management, you're gonna want to be aggressive with IV fluids for these patients. We prefer LR over normal saline. There's just been some small studies to suggest that it's better, but that's what we would recommend. And then as far as like the amount of fluids, again, there's not like a right or wrong answer, but the recommendation is 20 milliliters per kg bolus, and then follow that with 3 milliliters per kg per hour of maintenance fluid in the first 8 to 24 hours. And you should be trying to do goal-directed fluid resuscitation, so you can repeat their hematocrit or their BUN. And if those are coming down, you know they're responding well to fluid, so you can decrease the rate of your maintenance fluids. And since you're being so aggressive, you just got to be careful because a lot of our patients have comorbid conditions. So be watching their volume status closely. You know, in years past, we were very strict about being NPO when patients had pancreatitis. Now we've kind of softened that rule. We should be encouraging early PO intake in mild pancreatitis if they're tolerating it, if they're, you know, able to eat. And then enteral feeding is preferred over parenteral. All right, so that's it for emergencies. Just a few scenarios about those things and where you might find yourself throughout the year. So it's 3 a.m. You get paged by the nurse. Mrs. Jones just vomited blood. What do you do next? A, ask for vitals and go evaluate the patient immediately. B, tell your senior and await further instructions. C, call GI immediately. D, do nothing. It's tomato juice probably. What do you guys think? A, yeah. Yep. You should go see this patient first, evaluate them, and then decide from there. Okay, scenario 2, it's 5 p.m. You just admitted a patient with abdominal pain. The abdominal x-ray just came back and it shows a large bean-shaped sigmoid colon. What do you do next? A, call surgery immediately. B, wait to call GI in the morning. C, sign out to the night intern immediately and tell them to call GI. D, call GI immediately. If anyone says C, it's bad. Don't do that. I think we all know it's D. GI would be the one to manage this prior to surgery, unless there's alarm symptoms. Okay, so it's 4 a.m. and your psych patient that's admitted to general medicine decides to swallow a razor. The patient is completely asymptomatic and running around the halls. What do you do next? A, call surgery. He's probably perforated his esophagus. B, nothing. The patient is asymptomatic. C, check an FOBT. D, call GI immediately. Anyone? Yeah. Don't check an FOBT. Okay, there's a transfer from an outside hospital overnight with elevated LFTs. The patient is homeless and is an IV drug user. The ED states the patient is fine, just needs transfer to Loyola because there's no gastroenterologist there. You review the labs and note the ALT is 2,000, AST is 3,000, ALK Phos 100, total bilirubin is 1. What should you do next? A, admit to the floor, check repeat set of labs, send acute HEP panel and acetaminophen level. B, go evaluate the patient immediately for mental status changes, check INR, consider admission to the ICU. C, call hepatology first. Those numbers are really elevated and the patient could have acute liver failure. D, ask the ED to admit the patient to hepatology. What do you guys think? B. Yep. Go see, if you can make the diagnosis of acute liver failure. And then the last one, it's 2 a.m. You get a call from the nurse that Mr. Smith is complaining of abdominal bloating. You quickly look at the chart and see no BMs in the last week. You're very astute and decide to order a KUB, which shows significant colonic dilation, and a cecum up to 12 centimeters. What do you do next? A, go evaluate the patient. The patient has some bloating, but no peritoneal signs, so nothing to do. B, call surgery. The patient might perforate. C, go evaluate the patient and call GI. D, administer neostigmine to the floor immediately. I think I heard C. So yeah, that's correct. All right, so that's it. Does anyone have any questions about any of those things? Okay, great. You're welcome.
Talking about you the other day.
Uh-oh.
About that one time that I signed the